From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello, and welcome to our listeners around the world. You are listening to JAMA Oncology Author Interviews. Thanks for joining us. I'm Vivek Subbiah, medical oncologist, Chief of Early Phase Drug Development at Sarah Cannon Research Institute, Nashville, Tennessee. I'm also the JAMA Oncology podcast host for today and the web editor for JAMA Oncology. Over the past 40 years, the battle against childhood cancers has seen remarkable victories in the field of oncology. Today, more than 500,000 individuals in the USA stand as living testaments to these advancements, having triumphed over cancer in their childhood. Yet, as these survivors journey into adulthood, they encounter heightened risks, including secondary cancers and heart-related issues. Intriguingly, some reports suggest that these individuals may also experience signs of accelerated aging. In an insightful paper published in JAMA Oncology titled Accelerated Aging in Survivors of Childhood Cancer, Dr. Ye from Boston Children's Hospital and Dr. Diller from the Dana-Farber Cancer Institute and their team delve into this phenomenon of accelerated aging among childhood cancer survivors, shedding light on this complex and emerging challenge. In today's JAMA Oncology podcast episode, we are joined by experts, Dr. Ye and Dr. Diller, who will illuminate this complex topic and discuss the nuances of aging in childhood cancer survivors. It's a pleasure to have you both, Drs. Ye and Dr. Diller. Can you please introduce yourself? First, let's go with Dr. Ye.
Thank you, Dr. Subbiah. We really appreciate you having us here today to talk about our paper. I am a decision scientist and associate professor of pediatrics at Boston Children's Hospital and Harvard Medical School, and my research focuses on using mathematical simulation modeling to find ways to improve health outcomes at the population level. I focus mainly on cancer, and my work spans across the cancer continuum, including from prevention all the way to, as we'll talk about today, survivorship.
Thank you so much. It's a pleasure having you here. Dr. Diller, do you want to introduce yourself?
Sure. Call me Lisa. Nice to meet you, Vivek. I'm happy to be here today. I'm a pediatric oncologist. My research focuses on survivorship. This stems from my early experience as a pediatric oncologist caring for patients and then watching them grow old over time or older and asking questions about their health as they age. We provide care for survivors here at the Dana-Farber in specialized clinics. And during my career, we've noted more and more kids, now adults, coming in with secondary cancers, with heart disease, and with real questions about what will happen to them in their middle and late stages of life. And for that reason, Jennifer and I have collaborated to help understand that future for these patients.
Thank you so much. Again, being a med-peds oncologist myself, trained in both adult and pediatric oncology, this topic is really close to my heart. And it's a pleasure and honor having you both here. So let's start with our first question. So what inspired you to embark on this study? And how would you describe its significance to a broad audience of JAMA Oncology?
I'll start with that one. I'll go back to my really early inspiration. I remember one of my first patients as a pediatric oncologist came into the clinic. His name was Jack, and he had had Hodgkin's disease in the 70s, and he came in now in the late 80s, early 90s, a long time ago when I was a fellow. And he had had a variety of late toxicity from his therapy. So he had had thyroid cancer. He had had overwhelming sepsis from having had a splenectomy. He had had episodes of zoster. He had had radiation-induced carotid artery disease. And now he comes in and he's lost weight and he has abdominal pain and he goes on to be diagnosed and then subsequently succumb to secondary gastric carcinoma from his radiation. And I said to myself, what is this? What are we doing? Who are we curing? And what are we sending them forward to do? And during my time independently working as an investigator, I started to sort of develop small cohorts of patients here at the Dana-Farber and then got involved with a very large cohort study called the Childhood Cancer Survivor Study. And during that time, I met Jennifer, who's able to use her skills and her ability to project into a future where we can measure what might happen to our patients.
All right, Dr. Ye, do you have anything to say about this?
I just want to add how the work that Lisa and I do together really is such a labor of love, and how it brings together some mathematical modeling methods with the data that we have that's been collected over 3 decades of survivors, and using it to really try to enhance our understanding and to provide some sense of what survivors may face as they age, so that we can improve their care and improve their long-term outcomes.
Wow, what an amazing partnership with an oncologist, clinician, and a decision scientist. Next, question I got for you is, can you describe the major findings of your study?
Our study focuses on 5-year survivors of childhood cancer, and we want to look at their trajectory of health outcomes over the course of their lifetime. We focused on 8 chronic conditions. These included 6 aging-related diseases that are common in the general population and among survivors, as well as 2 common life-threatening secondary cancers among survivors. So I'll just list those so we have a sense of the conditions. They're secondary breast cancer, colon cancer, heart failure, myocardial infarction, valvular disease, stroke, glial tumors, and sarcomas. And we also accounted for excess mortality risks from other chronic conditions outside of these 8, knowing that survivors are at risk for many chronic conditions aside from just this small subset. And we found in the study that survivors were 2.7 times more likely to develop one of these conditions before age 65 compared to the general population, and more so that they experienced early onset about 2 decades earlier than individuals that did not have a history of childhood cancer. We also found that in terms of earlier onset and excess risk of these 8 chronic conditions, which was our proxy for accelerated aging, that the risk was higher among individuals that had received radiation as part of childhood cancer treatment, but that even survivors that were treated without radiation would experience accelerated aging, and that the magnitude and timing of this accelerated aging did not really vary substantially when we looked at survivors diagnosed over 3 decades.
Fascinating. Let's dive into the methodology. So you talk about COMPASS, right? Can you explain the cancer outcomes microsimulation, pediatric and adolescent survivorship, the COMPASS model in more detail? How does it uniquely contribute to our understanding of accelerated aging in childhood cancer survivors compared to traditional observational studies?
That is a great question, something I'm so happy to discuss with you since we spent many years developing this model. We were so excited to have our first analysis published using the model. So many cohort studies follow and provide very important and good information on survivors in the immediate decades following their childhood cancer diagnosis. But beyond that period of observation, we're left with less data about what happens. And so in this modeling project, what we did was we leveraged data from the Childhood Cancer Survivor Study. We used data from over 20,000 survivors, and we were able to then use that data to understand how different treatment exposures, cancer characteristics, and patient characteristics influence the risk of these different chronic conditions in conjunction when incorporating age-related risks that these survivors will face. And for those, we use data from the SEER program and other databases to account both those aspects of these different forces that will be driving the risk of these survivors as they age. And one nice thing about this project, or the model, is that you simulate this cohort of individuals as we follow them over time. And that allows us to project long-term outcomes, but also some outcomes of what happens to survivors once they reach certain ages. For example, in the model, we looked at what happens to the risk of these 8 chronic health conditions when survivors make it to age 40. How about when they reach age 50 and 60? And what we found when we looked at these estimates compared to general population estimates, which we also simulated using the same model so we could make sure we were comparing apples with apples, we found that there was no age at risk at which the elevated risks fell to the general population levels, which we found to be a very important insight from this analysis.
Thank you so much. So let's ask a clinical question to Dr. Diller here. So your study highlights the ongoing risks even with advances in treatment protocols. How do you envision future treatment modifications like reduced radiation or even targeted therapies impacting the long-term health outcomes for childhood cancer survivors?
As you know, over the decades that we've been curing childhood cancer patients, we have continued to intensify therapy for some patients, but for other patient groups, we've really focused on long-term survivorship to try to reduce some of these late toxicities that we've seen. So the classic example is the near elimination of radiation therapy as part of acute leukemia treatment. So at the onset of cures for childhood cancer, all children pretty much received cranial radiation as part of their therapy. And now only a very small fraction of kids receive cranial radiation. So we really have learned that by studying survivors and then taking that survivorship information and changing therapy, we've learned to what we think is reduce those risks. I think that will happen going forward as well, both as you mentioned, the reduction of radiation, the use of focal radiation, the substitution of targeted therapies for more broad cytotoxic therapies like high-dose cyclophosphamide and other agents. And I think that we have to very much continue our observational work as we use new therapies to understand the late effects of those therapies too. One lesson learned from the oncologists who first treated children in the 70s and 80s is that they knew they needed to follow these kids and figure out what was going to happen as they aged. And I think it's imperative that we continue to do that for the very same reason. In terms of targeted therapies and what we know now, we're beginning to get some information about some of the tyrosine kinase inhibitors and the impact on growth in cardiac disease. But it will be a couple of decades before we have true information to measure the effects and then compare them to the sort of standard therapy that have been used in the past few decades.
Thank you so much. So given your findings on the accelerated aging and aging-related diseases, what are the key preventive measures or screenings that should be prioritized for childhood cancer survivors? And most importantly, at what age should these interventions begin?
Well, I think this is a great question and really highlights why we selected some of these aging-related diseases. So many of the diseases that we've selected have established interventions to reduce the risk. So for example, for breast cancer, there's early initiation of breast cancer screening with the mammography and MRI. And also there is primary prevention with tamoxifen. So for several of the diseases, there are effective interventions that are established that are currently recommended for high-risk individuals or average-risk individuals. And so we're hoping that these analyses, by showing that survivors will encounter these risks decades earlier, that they can start the discussions with their physicians and the providers that care for them about starting some of these prevention efforts much earlier than they may have been discussed without regard for their history of childhood cancer.
In fact, we can use modeling to look at the impact of some of those screening methods or prevention methods. A current study that Jennifer is doing, that I am on the team for that study, is looking at initiation of tamoxifen in childhood cancer survivors and projecting forward what impact that might have, as well as cost effectiveness or cost benefit ratios associated with that. Another study might be coming down the pike, which tells us a little bit more about colon cancer screening in childhood cancer survivors as well. So the power of using models to project into the future if you make a change in the present has really become clear to me as a clinician in terms of the importance of doing this kind of work.
And thank you so much for addressing the elephant in the room, which is the financial and cost considerations as well. Thank you so much. Dr. Ye, go ahead.
I just want to add the goal of some of the modeling work, while the economic implications are important, but also just understanding what the benefit of undergoing routine screening among survivors or initiating primary prevention such as tamoxifen is really to help survivors and their care providers understand what the benefit might be if they undergo prevention, with hopes that will increase the uptake and adherence to many of these strategies for which the uptake rates have actually been shown to be low among survivors. We know that these treatment advances have led to an increase in the number of children diagnosed with cancer that make it to 5 years. And the second piece of that is to make sure that they continue to monitor their health and do what they can to mitigate the late effects to enhance their long-term survival.
Thank you so much. So let's talk about long-term healthcare planning. With the knowledge that survivors will have greater healthcare needs as they age, what are the implications for healthcare systems and policies to ensure these individuals receive comprehensive and timely care throughout their lives?
It's a very complicated question you're asking. I, as a pediatric oncologist, hold a lot of knowledge about how children who were treated for neuroblastoma in the 80s or the 90s or the aughts were treated. And to expect a primary care provider taking care of a 50-year-old 3 decades from now to understand what that treatment was and how to care for that patient is not really reasonable. On the other hand, it's not really a good idea for me as a pediatrician to care for a 50-year-old. So finding the right health care for these patients has been challenging. A couple of things that we have focused on as a community is development of a individualized survivorship care plan, constructed usually by the pediatric oncologist as the patient graduates to adult care, and survivorship guidelines, which are publicly available online through the Children's Oncology Group. And I think it's survivorshipguidelines.org. And one can then look through that document and look at the exposures that the patient had and what the current recommendations are for care as they age. And those are reviewed by expert panel on a regular basis. In terms of the overall healthcare system, I'm not exactly sure. It's an interesting question, isn't it? Because it's also true of survivors of much more common cancers, like young women who had breast cancer. Who should care for them when they're 60 or 70, and what their special needs might be because of their breast cancer treatment at a young age. So it goes beyond just childhood cancer survivors, as there's a growing population of people who are cured of cancer. Is it the generalist who should care for them? Is it the oncologist? Is it a specially trained group of physician extenders? Is it the patient responsible for that care coordination? Is it their healthcare provider? It is a very complicated set of questions because it's kind of like a new chronic disease that we haven't had before.
Thank you so much. Again, let's go to the final closing thoughts. Dr. Ye, do you want to go ahead?
I just want to end by thanking you for having us on this podcast. It's really exciting to share this work and talk about more in depth, especially with the combination of talking about the methods and the data and really leveraging those to enhance what we know about survivors. And then working with Lisa, just how it actually, just the whole context of caring for these survivors. Even as we talk about it here, I find myself thinking of new ideas to extend the model to look at. So thank you.
Thank you for having us. This is really a labor of love and involves a very large team of statisticians, other childhood cancer survivorship experts, and what we call modelers and people whose work at the computer is really beyond me. And so, as Jen says, it's really nice to sort of have that theoretical meet the clinical, and having JAMA Oncology recognize that modeling is an important way that we can understand cancer and cancer survivors, I think is wonderful. So thank you for having us.
Thank you so much. I'm Vivek Subbiah. I've been speaking with Drs. Jennifer Ye and Lisa Diller on accelerated aging in survivors of childhood cancer. You can find a link to the article in this episode's description. This episode was produced by Shelley Stephens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.